GIT presentation number 3, oesophagus presentation number 2. First, we'll talk about some ulcers. It could be due to reflux, could be due to infection like AIDS and Candida, or drug induced. Reflux esophagitis, here we have some minimal narrowing along the esophagus, and if you look carefully you might find some serrations along the wall. Here is definite differential should be discussed. We have pseudo-diverticulosis, or we have reflux esophagitis, or this is herpes. Intramural pseudo-diverticulum will be mistaken for small ulcers associated with reflux esophagitis or herpes. So herpes and reflux esophagitis are similar to give small erosions. The flask-shaped or floating nature of the diverticulum when viewed in profile allow distinction. You can see a diverticulum like a small body with narrow neck. Double contrast of GIT shows numerous 1 to 2 millimeter barium collections protruding from the esophagus wall into the wall. Some of the barium collections are flask-shaped. The tiny collections are seen on face or round, linear, or ovoid. For this case, have intramural pseudo-diverticulosis plus some ulcerations on the surface. Here there is enlarged folds, prominent folds in case of reflux esophagitis. Submucosal spread of squamous cell carcinoma may produce thick undulated folds. However, the surface of the fold is often nodular, and the tumorous folds do not change size or shape. Dysphagia is more frequent in patients with varicoid carcinoma. This the pattern of carcinoma that is creeping underneath the mucosa is called the varicoid mucosa, varicoid carcinoma. Lymphoma also infiltrating the esophagus can mimic varices. So this appearance of reflux esophagitis with gastric with esophageal mucosa appear thickened could be due to also of creeping mucosal carcinoma, submucosal carcinoma, or creeping lymphomatous infiltrations along the esophagus. So giving the differential of varicoid carcinoma or lymphoma of the esophagus, and even varicosis of the esophagus can produce such an appearance if it is smooth enough. But reflux esophagitis are not smooth. Reflux esophagitis are irregular. Candida esophagitis, again we have these thickened mucosal folds, we have these fine nodulations and irregularities, and we have these small ulcerations along the surface. This is Candida. Acute erosive corrosive ingestion or a longitudinally spreading carcinoma or Candida esophagitis. Of course, this appearance is more with this patient with thick irregular esophageal mucosa, but there should be a history for corrosion. If you exclude corrosion in such case, this is appearance of again varicoid pattern of carcinoma, or sometimes it is Candida esophagitis which can produce such an appearance. Thick irregular mucosa. Differential diagnosis: 1, reflux esophagitis; 2, creeping varicoid carcinoma; 3, lymphoma. 4. Candida oesophagitis. Here is actinomycosis in AIDS. Can give such ulcerations with these ulcers connecting to each other, leaving a double outline of the esophagus. The differential diagnosis here is varicosities, reflux esophagitis, varicoid carcinoma, and lymphoma. Don't forget these 4. Aspirin esophagitis here manifests as small, very small ulcers along the esophagus wall. Solitary esophageal ulcers, of course, we have in cytomegalovirus and in AIDS. Ulcers are shallow craters with thin, smooth edges. The edge of the ulcer is thin because there is little inflammatory response. Drug-induced ulcers arising in Barrett esophagus or in ulcerating carcinoma are usually deep depression with thick nodular edges. Diagnosis is a combination of clinical history and biopsy. Such ulcers could be due to cytomegalovirus, could be due to AIDS, could be due to carcinoma, could be due to esophagitis. So the main diagnostic tool is, after clinical examination and history, is biopsy. Now strictures. We have distal esophageal strictures. For example, peptic ulcer, peptic strictures, Barrett strictures, carcinoma will be checked in part 3, and the carcinoma could be gastric, could be esophageal. Achalasia we checked it already in part 1. All of these can give distal esophageal strictures. So they include peptic ulceration, peptic stricture, Barrett stricture, carcinoma, achalasia. These are the most famous for the distal strictures. Distal stricture due to sarcoid. It's a smooth stricture, but again biopsy is needed because there is an area of irregularity and apparent shoulder. This is a stricture of scleroderma, connective tissue disease, and here of course we can get impacted foreign body, so it should be excluded as an achalasia or carcinoma. These are the 3 main groups. Postoperative hernia with fundoplication. Now we have a stricture and have narrowing. Achalasia, of course, have distal stricture. Distal esophagus stricture showing the beak-like narrowing. The esophagus is dilated above, and the uppermost stomach is collapsed. And we have, of course, the primary achalasia of Chagas and amyloidosis and diabetes, and in all these we will find the beak-like narrowing. Secondary achalasia after vagotomy, after carcinoma or hematogenous metastasis or lymphoma, and here we get irregularity, and usually the dilatation of the esophagus is not that of achalasia, and usually the segment involved is short and irregular and may show the the rat tail appearance and shouldering. So what is the differences here? Here we can get short segment of narrowing with shouldering. Here we can get a long segment of narrowing with barred beak appearance. This is achalasia, this is stomach carcinoma. And here we get the impacted foreign body, which could be differentiated also from a small polyp or mass, but here the esophagus below is showing short narrowing with irregularity and shouldering, and here is some hiatal herniation. Mid-esophageal and long strictures, we have radiation, mediastinal masses, corrosion, NG tube, prolonged use of the NG tube. This is typical appearance of corrosive stricture or benign stricture, where is a long segment of affection with moderate to marked dilatation above, and here the cause is either peptic or mainly caustic. Radiation can reduce mid-esophageal stricture like this, usually with smooth margins. Progressive corrosive stricture here, long segment of narrowing with mild dilatation above, and there is irregularity of the outline denoting associated ulcerations. Barrett esophagus versus adenocarcinoma, because the short narrowing is also of irregular margin and presents appearance like shouldering, so we have to differentiate from adenocarcinoma. Thickened mucosal folds is another subject which could be due to varices, varicoid carcinoma as we said before, reflux esophagitis, and lymphoma. These four will be always mentioned whenever we find thickened longitudinal esophageal folds. So here is the appearance of varices as tubular filling defects, but still we have to consider varicoid carcinoma, you can consider reflux esophagitis, and you have to consider lymphoma. Of course, once there is history of hepatitis, there is clinical suspicion of varices and bleeding, the appearance is in more favor with varices. For example, you find hepatosplenomegaly. The presence of varices along the esophagus is usually with smooth outline like this, smooth longitudinal folds. And don't forget that not only the esophagus is involved in such varices, but also there is something called gastric varices and paraesophageal varices. So we have gastric and esophageal varices. This is gastric and this is esophageal. This is gastric and this is esophageal. Now, I think the irregularity is evident, and it is different from that of longitudinal filling defects of varices. So we could put varicoid carcinoma, and we can put lymphoma because it is more applicable here. These are different appearances of varicoid carcinoma. It seems as if like varicose, but it is due to creeping gastric, carcinoma in the submucosa, eroding and causing lobulated and nodular appearances along the outline. So it is definitely, the appearance is different. Thank you.